Welcome back. Professor Vicki Anderson is Director of Clinical Sciences Research at the Murdoch Children's Research Institute here in Melbourne, and recognised, and I think it's safe to say renowned internationally, for the specific considerations due to the concussed child or adolescent. Please welcome Vicki.
Can people hear me? Yes, good. So thanks, Nick, and it's great to be involved with Brain Injury Australia and have an ongoing relationship with it in the work we do at the Children's. So I'm going to kind of change the topic a little bit to talk about children and youth. And like Michael, I'm involved in the International Concussion in Sports group. And I'm primarily involved in that because there's not much that they do in kids. In fact, it's really hard even to define what sport is in kids. So it's an area that we're putting a lot of work into, particularly the kids under 8. So I'm not going to talk much about that. That's our challenge for the future. But I want to maybe give you a bit of a context. So I'm a clinical neuropsychologist and interestingly, I completely agree with John about the use of neuropsychologists in concussion. So I hope there's none of my colleagues here that I've offended by saying that. But at the Children's Hospital, many of you may know, we're a research institute, a hospital and a training facility. So our concussion program is very much clinically oriented. I'm going to talk to you today about some of the information that's come out of it's called the Take Care program. And I suppose just to start with, it's what we've tried to do. Most of our research is funded by the public purse, and so we've tried to develop resources for kids and families where there's been a concussion occur that are accessible to all. So you've seen the Head Check app, and I'll talk to you just briefly about that, but we've also got a number of interventions that we've built to be able to be delivered in hospitals and in private practice, but under Medicare cover. So with that in mind, I just thought I would give you a bit of a picture of a case, and it's actually really fortuitous that Jacob's case, Jacob's problems that he described were very much in the physio area. And Mia, the girl I'm going to talk about, her problems were very much not in the physical area. So just a little bit of background on Mia. She was 16, classic kind of symptoms of someone that has ongoing symptoms. So she was an excellent student and athlete. She hadn't had any prior concussions, no medical history, no mental health problems beforehand. She was an excellent sailor, and she was hit by a mast when she was sailing in a championship down on the Mornington Peninsula. She had a few initial symptoms, headache, which is the most common symptom that we see in kids, and some nausea as well. But she went home, she had a good sleep, she came back the next day to continue on with the sailing championships. And when she got home that night, she just was absolutely exhausted and very symptom loaded. Now, it isn't very long ago that she had this injury, but she was given the advice and I must say it wasn't from a GP, so she was given some advice that is very much out of date these days. So go home, no exercise, no screens, complete rest until your symptoms are all resolved. Now think about if I don't know if any of you have got 16-year-olds, or if you remember when you were 16, if you have to sit in a quiet dark room for days and days and days, what do? You worry, you think about things, and so that's very much what happened to Mia. So we saw her at 2 months. She had ongoing symptoms. She was unable to return to exercise at all or to school. She was having daily headaches, excessive fatigue, all the kinds of symptoms that you've heard about already today. So she's a really good example of concussion that leads to this disruption of normal activities, unclear or maybe inappropriate recovery expectations, And in this case, this leads very often, we see, to increase not just child anxiety, but parent anxiety as well. So the longer kids take to recover, the more anxious parents get. So there's a cycle where the symptoms get exacerbated and then recovery is prolonged. So we know that there are some things that help that, and we also know, as has been said before, that the earlier the intervention, the better. And so what I'm going to talk to you about is early intervention and a variety of different approaches to that. But before I do that, now you've seen this definition a few times already today, but I just wanted to put it up because this is a definition of concussion that we use in our research. So this means that all of the data you'll see will fit with kids who have had these kinds of symptoms. So just to start, before I go into our interventions, I want to give you a bit of context of why we've gone down this track. And I want to talk about what the community knows about concussion. Firstly, there's science, and that's what we here know, and the scientists in their ivory towers know. So we know that there's some literature out there around the impact on brain through MRI scans and so on. We know there's some literature around there about blood biomarkers, and more recently some information about mental health problems. The problem with all of this literature is that there's a selection bias, and I want you to think about this when you're reading the literature in the future. So most of the research that you read will be from outpatient clinics. So the adults and kids that have recovered don't come to those outpatient clinics. And so if you're in one of those contexts, you get a biased perspective of how many people have symptoms after concussion. And in fact, as again others have said, there's a number of factors that go into these long-term problems that we see. Again, in terms of what we know, there are many guidelines. We've talked about them today. AFL have got guidelines as well. That's an old version, Michael. But if we ask the families that come to our emergency department with a child who has a concussion, not surprisingly, 90% of those families have no clue that those guidelines exist. Only 40 to 60% recall ever getting that piece of paper or that card that someone else was mentioning in their hand when their child is discharged. And 42% of the kids that we saw in our ED were not managed according to guidelines. So that's a really big problem. And what happens as a result of all those things is that there's high levels of anxiety in parents. And in fact, I'll give you a little bit of the conclusion to what I'm going to say. Parent anxiety is one of the greatest predictors of prolonged symptoms in kids. So the more anxious the parent is, the more likely the young person is to have ongoing symptoms. I'm not saying, when I say that all prolonged symptoms are due to that. I'm just saying that it's a big issue, and what I really want to raise when I've said that comment is that the information that parents get from the community, from the media, is very biased and very sensationalised, and so it scares people, not surprisingly. So when we actually went in and did our annual Royal Children's Hospital poll with about 3,000 kids last year, what we found, so this was a poll specifically on concussion, this is some data that shows you how many parents felt that they had good knowledge of concussion. So the green, which is obviously the majority of this, is some knowledge and a lot of knowledge, but most people felt that they didn't have sufficient knowledge. 65% of parents limited their child's activities due to concerns about concussion. 85% weren't confident that they could recognise the signs of concussion that we've been talking about today. And 28% have stopped their kids from playing contact sport. And that's a real worry because contact sport is part of development. It's part of growing up and getting used to competition. It's part of being healthy and having challenges. And in kids, it's only about half of the story in terms of the proportion of concussions that occur. And the last piece of data I'll show you from this is this was a question we asked, that if your child had had a concussion, how confident are you that you would, number one, know what to do? Not very many people thought they would know what to do. See a doctor. Again, it's only about a third of people would see a doctor, would take their child to see a doctor. And then the last one is know where to access care. And I want to just point out that all of that group were accessing care by going to a GP or to the ED. It wasn't the recovery stage of thing that they were thinking of. So why is this important? So if you look at the data in the research literature, about 16% of kids will have had a concussion by the time they're 10. And the hands that went up when you were asked who'd had a concussion before kind of bears that out. And I've just put some data on 4 million presentations for concussion to EDs worldwide every year. And with kids, about 30% of that group will go on to have delayed recovery. So 1 in 3 kids will go on to have delayed recovery. And we define delayed recovery as symptoms after 2 weeks. So 2 weeks with symptoms is fine. After that, we call that delayed recovery. So let's look a little bit at the process. So in terms of what happens after a concussion in kids, so they might have a head knock. They are either sidelined for the game, if the coach can manage to convince the parents and the child that they can be off the ground. They're either told to go to, recommended to go to a GP, or they're taken by ambulance if they've got symptoms like lengthy loss of consciousness or seizures. And from there, as we've already heard, there's graded return to activities, which is usually enough for 70% of kids. So rest, not complete rest, but mostly rest, no wild parties and things like that, for 48 hours, and then gradual return to exercise, school, and symptom resolution, with the speed of that depending on the child's symptoms. For the other 30% of kids, it's much more complicated. So what we see, and it's already been commented before, is there's this circular kind of interaction between these symptoms. So headache and fatigue, oculomotor and vestibular issues, and mood and adjustment problems, and they all feed off each other. I do want to note though that it's really important when you're looking at those symptoms that you ask the person who's rating their symptoms whether or not they had the symptoms before their concussion, because most of the symptoms that are in your checklists are also very common in the community, so you don't want to over-diagnose these things. So from this point on, I'm really going to talk about delayed recovery and what we do about that. So just a few pieces of information about what we know. So as I said, around about 30% of kids will go on to have these persisting symptoms. We know a little bit from longitudinal prospective research of concussion. We know that the biggest predictor of persisting symptoms is the symptom load acutely. So the worse the symptoms are when you see a child in the ED or in your consulting rooms, then the higher risk they're going to have of ongoing symptoms. And I'm talking about kids when I say older age, so adolescents are more likely to have persisting symptoms than younger kids, and females are more likely to have persisting symptoms. I just want to spend 1 minute thinking about that, because if you actually look at those pre-concussion symptom ratings in women, in girls, they're actually quite high. So that's one of the areas where you really have to look at whether or not the symptoms are due to the concussion or they're innate. And then some of the other predictors, the pre-entry predictors, migraine we've heard about, psychiatric diagnoses, prior concussions with prolonged recovery, and child temperament and parent stress. So they're all of the kinds of things that we need to think about when we've got someone in the ED or in your GP rooms who looks like they're going to be in trouble. These are the kind of symptoms that we're looking at. So we divide them into these areas: physical, somatic, cognitive, emotional, and sleep and fatigue. And you've heard about the SCAT-6 and the SCOT-6. And just maybe to note, there's child versions and adult versions of those. And with the SCOT-6, we're really suggesting that that is best used in a multidisciplinary clinic, because there's now quite detailed physio and psychology input there. So it's really something that's a little bit more detailed than the physical exam. So we've heard that these symptoms are heterogeneous and that they can amplify. So I just wanted to highlight some of the areas that we need to think about when we're looking at these symptoms. And it is important to note when I talk about this that I'm a psychologist, so I come with a bit of a bias towards the mental health basis of these issues. So pre-injury issues, you can all read those. So other physical and health-related issues, lots of times kids will come into the children's with a broken arm or a broken leg or lacerations, and the concussion will be completely missed. So those kids will come back later complaining of the symptoms that we see. Whole range of psychological factors we see, and post-traumatic stress symptoms is probably a key one here that isn't often thought about. And then environmental stresses like academic stress. So Jake was saying how stressful it was to be in year 11 and missing out on school and feeling the need to catch up. That's a really common story that we hear. So what do we do to solve these problems? So in our team, we have a multidisciplinary approach to treating these symptoms. The model is individualised. It's targeted to the symptoms that the child presents. So if someone's anxious, we don't send them to the physiotherapist. If someone's got physical symptoms, we don't send them to the psychologist. What we do see over time is that there's a crossover in what's needed, but I'll talk about that later. So sports medicine, primary care, really important. Physiotherapy is really important. And I've got neuropsychology there, but I would really leave neuropsychology until we're getting into the really chronic symptoms that occur after a concussion, because, as John said, in those early stages you can't differentiate what's actually cognitive problems from all the other symptoms, and then mental health's really important. So this is the kind of model we have, a biopsychosocial model, and I'm sure many of you are familiar with this. So we've got three time points in our model, as you see there: prevention, intervention, and then chronic treatment. So let me put it along the graduated approach to care model that others have mentioned. So we have an injury, and at that point in time we recommend the use of the Head Check app for kids and adolescents or their parents, because what that does is it takes in the symptoms that usually the parent rates. So based on those symptoms, then the recovery activities are tailored to those specific symptoms. So very much Head Check is about giving information, psycho-ed, normalising the recovery from a concussion for kids and adults, and giving families information about what kids can be doing and how you go about that graduated process. So then we move on to our Concussion Essentials modules. So we've got two different components to this. So we've got the early recovery, which is the early intervention model, which is called Concussion Essentials. I'll talk you through it in a moment. It's basically an 8-week program, two weekly sessions of an hour or more, and the target is the symptoms. So as I said, I'll talk you through that in a minute. And then for kids who are still symptomatic at 3 months, or who present to us at 3 months, we do a similar kind of program, but with some different little bits and pieces. So here's Head Check. Let me just give you a little bit of an idea. Now, I've shown you this kind of model already of recovery. So what happens with Head Check is it's used on the sidelines. If a child's playing sport, it's on your app or your Samsung phone, whatever you've got. Once diagnosis has happened, then that information can be automatically transferred to parents via an email, and then that recovery process starts to happen. And as you can see, it starts with that first 48 hours, going on to school, then going on to organised sport, and then to medical clearance. This is what it looks like. So you're putting in the middle one there, you can see that you're putting in symptoms that the child's got and how serious they are. And the parents can track how their child's recovery is going over time. And then that last panel there is the kind of the look of the kind of recommendations for activities over time. And it lasts for between 2 to 4 weeks, and at that point in time, basically we think that if you've still got symptoms, you need to be doing something about it, and several people have said that already. And so that's when these other interventions kick in. I should say that these interventions are really based on clinical practice. So the physio components are all what sports physios would be doing in the community for kids or adults who have concussion. And similarly, the psychology components are very much around what a psychologist will be doing to solve the problems that the young person's having. So let me just give you a little bit of a look at what things we do. So we have 3 different modules that the clinicians in our team choose from each week when they're going to see the child and family. And mostly we see kids and families together, the kids and one parent together. So we focus on the key things that are problems. So fatigue is a huge problem, as John said. That's a really, really big problem for kids going forward. Headache is the other problem that we focus on. So giving information, we did try giving exercises and homework between the sessions, but that didn't work. So we do it all in our sessions, just getting kids to think about how they can really introduce these kinds of methods into their day-to-day life. Return to school is a really important one for kids, and we get involved in that process if we need to, but mostly parents can manage that on their own as long as they have good information. And the physiotherapy is, as John has already described, so I won't go into that in too much detail. It's cervical spine, oculomotor and vestibular are the really key things that we're focusing on. And then the psychology at this point in time is a cognitive behaviour therapy model. So let me just give you a little bit of a look at what happens with this particular intervention over time. So what I'm going to show you here is if you look on the red box over there on the right, that's the group of kids that we saw before we did any interventions. And you can see that it's so it's right at the early stages. Mid-intervention is the 1 month mark, and then post-intervention is the 3 month mark. And you can see the symptom load in that group is really high. But if you look at these 12 participants who've gone through the Concussion Essentials program, what you see, number 1, is an improved understanding of the recovery process, which I think is really key to improvement of symptoms. Faster symptom resolution than the non-treated children. Reduction in symptom load across all areas, and it isn't in this graph, but faster return to school, leisure and sports. So it really does have an impact. Now, of course, you can say these kids would be getting better anyway, but to look at that, we're just almost finished a randomised control trial where we have a usual care group as well. And I thought it might be interesting, as there's a lot of physiotherapists in the audience, just to have a look at what these young people need when. So across the bottom I've got the weeks, so week 1 to week 8, and what we see is that there's initially significant physiotherapy input. So around about half of the kids need physiotherapy based on their symptoms in the first 3 weeks. That reduces fairly quickly, as does the need for psychoeducation. But what increases over time is the need for psychological input. So the nice thing about this particular group is that most of them, I think there was 1 child out of our group that still needed more intervention after the 8 weeks. So an argument for multimodal, symptom-targeted interventions, or a multidisciplinary context, I suppose, is the key thing. I'll just touch on the differences in our longer-term intervention, and someone mentioned mindfulness before. We've really moved to a mindfulness or acceptance commitment therapy approach, which the psychologists in the audience will be very familiar with. So the kinds of education we give is slightly different, although we've been really surprised at how poorly these young kids and their families at 3 months to 12 months after their concussion still having symptoms, how little they know about what concussion is and how it should be supported for recovery. So we still have to do a lot of education, and particularly in the sleep hygiene, headache and fatigue areas. Physiotherapy, again, many of these kids, even that long down the track, have never seen a physiotherapist. They might have seen 20 other medical or healthcare professionals, but they haven't really seen the key person. And as I said, the psychology is focused on more of living with your symptoms kind of approach. And we've just done a smaller study of that at the moment, and I thought you might be interested in seeing just how successful you can be, even at that stage when you might think that symptoms are ingrained. So this is parents' ratings of their recovery, and really important also to see kids' ratings of their recovery. And this is the first 10 kids that have gone through this process. So again, you can see that there is a reduction. And one of the nice things with this is many of these kids were in our usual care group for our trial. So they had 3 months where they could do many other things, but once they got into the trial, once they got into this end of the trial, they really benefited. So I think we're very pleased with these results. And these are some of the kinds of things that families said. Just let you have a read of those. So most of the families were very positive about the outcomes. And again, focusing on information, education, and listening to the child in front of you. So just in summary, just to remind you all, 70% of kids recover within 2 weeks. So we're really interested in this very top group. With respect to the kids that we saw in our longitudinal study, there was more recovery in kids over that next couple of months. So there's still about 30% until that very last stage where it's a really small proportion that have ongoing symptoms. So the other points I want to really emphasise is that the nature and severity of symptoms vary, which is why we can't say, as Michael said, you can't say 19 days is the amount of days that we need. Every person really needs a different approach and a specific tailored plan for their recovery. So in the first 4 weeks, we're focusing on normal recovery, and then after that, we start with really focused interventions. So in terms of key messages, I think that the ones from our program would be, let's normalise the recovery process as much as possible, with evidence-based information and management being available to young kids and families. Acute management is absolutely key, and early intervention is really important to minimise morbidity in these kids. Symptom-targeted early intervention, multimodal interventions, preferably in a multidisciplinary clinic, has promised not just in the acute stage but also the long-term stage. And I suppose the one thing I really want to emphasise with kids is establishing a balance between the risk of concussion and its potential consequences, and reduction in activity and its impact on child health and mental health. And just to my last word is, where does this all go from here? So we're just about to establish a clinic that's been funded by the Victorian Government that is going to put this model of multidisciplinary care into practice for kids and young people. And there's a lot of people who have contributed to this work over the years, and you can see that there's also a number of supporters of this group. The Victorian Paediatric Rehab Service, we've had competitive funding, and our hospital funding's also contributed. So I will leave it there. Thank you.